Hi, good morning, good afternoon, good evening, Call for Change participants. I hope you're all doing really well and you're excited to be starting the first session, Introduction to Health Promotion, Part 1. What I'm going to be doing over the next 10 to 15 minutes, let's see how we go, minutes or so, is introducing you to a new thinking around what is health promotion, how it can support you in your daily work. How can we think about it in a new way, potentially a way beyond the way you kind of understood health promotion in the past? And then my colleagues Lydia and Gail are going to add on to this with two more trainings over the next couple of days. So why are we here then? So to start us off, I can just move to the next slide. The objectives of this online session are really to think about and discuss the concept of health promotion, what it is, how it can help you in your daily work, and its evolution and role in influencing individual and community behaviours at the local levels. But before we begin, I want you all to get out a piece of paper and a pen and just to write down whether you think the answer to this question is A, B, C, or D. And then we're going to test how good I am as a lecturer over the next 10 to 15 minutes, so you can get this answer correct at the end of the session as well, if you haven't already, which I'm sure many of you will have done after our Idea Lab workshop. So, which one of these do you think is the best definition of health promotion? A, giving people information about how to improve their health. B, it's an approach aimed at improving the well-being and health outcomes of individuals, communities, and populations. C, it's a process of enabling people to increase control over and improve their health. Or D, all of the above. So let me just take 30 seconds or so, have a read through, and just write down what you think. A, B, C, or D. And there is no judgment here because you're only testing against yourself. We will not be marking this question. Okay. So with that, the quiz done, we're going to move now on to the lecture. So I want you all to kind of cast your minds back to this time, 3 years ago now. We all know that COVID has had a devastating effect on our health systems around the world, on the economy globally. It's had a huge effect on people's mental health, and it's reversed decades of progress, moving the Sustainable Development Goals even further back. So Antonio Guterres, the UN Secretary General, early on the pandemic identified that this phenomenon, that although the coronavirus has affected every person and every community around the world, it did not do so equally. And it's really exposed and exacerbated existing inequality and injustices. And these inequalities, these injustices were and remain present now in our health and social systems and structures. So I think, as many of you probably know, one of the really important facets of the call for change is to make sure that when the next pandemic or the next epidemic comes around, which it may do in our lifetimes, not once, but potentially more times, to make sure the next pandemic doesn't do this, that we are better prepared, that we're creating resilient health systems that really can reach everyone equally, and that we're able to kind of close this gap, which Antonio Guterres is saying here, especially in terms of where we've kind of where it's been exacerbated in the last few years. So you can see from these graphs here, so even before COVID, and these graphs are before COVID, kind of ravaged the health system, 75% of the Sustainable Development Goals indicators that touched on health, particularly for children, were off track in every country of the world, or we didn't have enough data to track their progress. So you can see across the top here, we've got indicators on survive and thrive, on learning, on protection, on environment, on having a fair chance. You can see in the blue in these graphs, the blue is where the targets had been met before COVID. And the red in these graphs is where acceleration was needed. But you can see here that we're really largely off track and that we really weren't going to be meeting these indicators by 2030, or at least it didn't indicate that we were on our way. And you can see from this graph here on the left that 36% of the survive and thrive indicators, which is largely where health falls in the SDG indicators, were off track even before the pandemic, even before COVID. And that about 23% of these gray areas, 23%, either had no data or had insufficient data to understand where we are coming from and where we would be. So in general, the take home from this slide is that even before COVID, there was so much work to be done in this space. And you can see that's the same for learning, protection, environment, and fair chance here. There's a lot of work to be done to meet targets. Either we don't have enough data, or there's a lot of work to be done to meet these goals. So what we want to talk about today in this first online training for the Call for Change is how do we use, I suppose, the devastation of the pandemic of COVID-19, how do we use it as an opportunity to do things differently? What if COVID-19, which had these devastating impacts in so many ways around the world, what if we could use COVID-19 to shed light on a new way of doing things all around the world, which is hopefully what we're able to do with all local amazing organizations we have here in the Call for Change. So there's a quote here on the right. Again, this was just after COVID hit. Louise Zenmin, who's the Undersecretary General for Economic and Social Affairs at the UN, she said that in the Sustainable Development Goals report that was released in July 2020, he said that business as usual will not be nearly enough, but we must find transformative pathways in turbulent times. So I think picture here is let's find a new way of doing things. What was happening before COVID wasn't working. We need to find a new way of reducing those inequalities and injustices. So what if local organizations here who are listening in, and the Kenya Ministry of Health already have an untapped superpower to design the future health system? What if you already have the power in your hands to change the way that the health system reaches and responds to and is centered around the needs of your local communities? Perhaps the superpower that already exists. So what if that superpower could improve existing services so they can meet people's real needs, values, and concerns? What if the superpower could find, track, and reach the people consistently left behind? What if it could leverage culture, belief systems, and norms for change? What if the superpower could support people to design their own solutions? What if it could build long-term trust and understanding amongst the most vulnerable communities? Maybe you can think about in your local area, where is there mistrust? What if there's the superpower to change the motivations and the trust of those local communities before a crisis strikes? Because we know it's so hard to build trust during a crisis. And what if that superpower could put people at the center of every solution? So what is that superpower? You're probably thinking, what is Flick talking about? So we think that the superpower itself is a new vision of health promotion. And that is a comprehensive and impactful vision of health promotion. And we're going to explain a little bit more about what that means. I'm going to start today, and my colleagues Lydia and Gail are going to dive into this a little bit more as well. But let's just think for a second, what do we mean by a comprehensive and impactful vision of health promotion? Well, to start with, it means people-centered programs. And let's use some examples to kind of illustrate that. So let's think about breast milk. Almost all mothers know that exclusive breast milk is the best nutrition for their babies. But most mothers don't exclusively breastfeed for the full 6 months. So you can imagine that what if we could harness this knowledge for breastfeeding and move it into actual behavior? You think back to that slide with the indicators. What if we could kind of, with this knowledge, really move those 36%, move it into actual breastfeeding? Let's think about another example. So we know that Ebola kills half of its victims. Measles kills 135,000 children every year. COVID has already killed over 6.5 million people. We know that vaccines can prevent these and other diseases. We know that already. We also know that there is rising hesitancy against vaccinations. A lot of people across the world protest against vaccines, and they would rather choose the risk of death over vaccination. What if we had a superpower that could really think about understanding why people are choosing a riskier health behavior over something that we know can actually save their life? Imagine if we could persuade people to save lives. Well, we think that health promotion and comprehensive health promotion is the superpower, and it has a huge role to play in overcoming some of these behavioral challenges. But the understanding of what health promotion is, how it can be used, the potential of it, and the role it has to play in changing behaviors, not just individual behaviors, but also social and large groups behaviors, has evolved a lot over the past couple of decades. As you can see from the slide, WHO, the World Health Organization, has moved the definition of health promotion away from prevention of specific diseases or the detection of risk groups. And within this traditional understanding, and you'll see in this next slide, health promotion was seen as being rather top-down. When we say top-down, we mean the decisions, strategies, interventions were made by people at the top, so at national or global levels, who may have fantastic knowledge and backgrounds and understandings of science, but didn't have very much understanding, comprehension of, or maybe even empathy with people from local communities at local levels, and lack of understanding really on how these communities or groups really made decisions and why. So really it was experts from higher up levels making decisions to move the needle at local levels. This kind of earlier definition of health promotion was individualistic. It really relied on quantitative evaluation. So for instance, using surveys, other data other numeric data to think about understanding what the problem really was. So that could be, for instance, sending out large CAP surveys or national census surveys with huge sample sizes to kind of give you a broad understanding of what was going on, but with little ability to kind of dig down into the real nuance and real reasons and in-depth understanding of the kind of the drivers behind those decisions and beliefs and motivations. It used RCTs, so kind of lab surveys to show evidence of impact. The challenge was that a lot of these RCTs were conducted in the global north rather than the global south. And so there's been a lot of discussion about how relevant a lot of the findings really are for real world settings. As you can see here, the effects, unfortunately, a lot of the effects were not really transferable to real life contexts. Now, we have this new version of health promotion and new thinking and new science of health promotion. It really thinks about how we can expand the definition of health promotion and the tools in the toolbox of health promotion to motivate and support people to make good decisions about their health. And the new definition, which we're going to be exploring the next couple of sessions, really draws on the social and behavioral sciences. Helps us kind of learn about people, to support people and design solutions with their needs, their values in mind as co-designers, as kind of authors. So the new version 2.0 of health promotion, which it kind of talks about in the slide, really values and has essential principles of dialogue and co-creation. So what we mean by that is that really giving local communities, health workers, individuals, family members ownership over programs, strategies, solutions, really helping to ensure a tailored approach, which is really centered on their needs. And really, this new version really speaks to increased sustainability of health strategies or other local strategies too, because owned by local people, designed by local people, hopefully be adopted and continued with local people. It draws on both qualitative and quantitative thinking, indicators. So really leaning not just into surveys, which are powerful tools, or other kind of quantitative tools, but really thinking about how do we actually collect more qualitative insights from, for instance, focus group discussions, interviews, observations, other data collection tools. So we can really start to dive deeper into what's really going on amongst hard to reach last mile communities and people. So we have some more nuance and deeper understanding of the kind of strategies and interventions that are really needed to reach these local groups. Also, the interventions that come with this kind of version 2.0 are a little bit more complex. And we touched upon this in the Idea Lab workshop as well, but one of the key solutions, which is an important solution, but not the full solution for health promotion that a lot of ministries of health and a lot of organizations use, is communication campaigns. So really, let's just tell people what they should do. Let's put up some posters, let's put up some wall murals, some radio campaigns. But as we've seen time and time again, this just doesn't work. It's insufficient. There's so much data and evidence out there now that says communication on its own does not really reach impact. So obviously the assumptions of these communication campaigns, as we all know, is that we just need better information and better knowledge to change behavior. But as we all know now, we need so much more than knowledge to really change behavior. And that kind of comes back to those slides on breastfeeding, on Ebola, on vaccination. Knowing that something is going to be good for you doesn't always lead to positive behavior. So the health promotion toolbox, this version 2.0, uses communications, but also leans on other tools and approaches in the SBC toolbox. That's, for instance, behavioral science, human-centered design, health system strengthening, marketing, anthropology, to really think about how we can really change behavior. And it does this and uses these tools in a coordinated fashion. So, and because it's owned by local people, we might find that actually health promotion doesn't just support health, it might also support social, education, quality of life areas too. And it's based upon studies in real life. So not just through RCTs, which are important, but also really thinking about gathering evidence about what's really worked on the ground. So with that in mind, let's everyone pull back up their piece of paper in front of them and have a think about, what did you put, A, B, C, or D? Well, hopefully has been articulated in the last slide. The definition of health promotion is A, B, C. It's all of the above. It's about giving people information through, for instance, communications and how to improve their health. But it's also an approach aimed at improving the well-being and health outcomes of individuals, of communities, and populations. And it's a process in and of itself to enable people to increase control over and improve their health. It switches that power dynamic from not just being top down, but to being bottom up. So local people can be kind of the authors of programs that really work for them. So I hope that makes sense to everybody now in terms of thinking, well, what is health promotion? It is a behavioral social science that focuses on people and how they behave, because everything we do is about people. And that is what we're going to basically explore in terms of the new definition of health promotion. How can behavioral science, how can human-centered design specifically really help us think about how people behave, and how we can use these tools and approaches to really input into your strategies. So some optional reading, which we'll send on the WhatsApp here. There's three different optional readings. You'll get top marks, of course, if you get through these. Share any thoughts, any other reading, any other news, clips, anything at all in the WhatsApp group. We want to hear from you. Hopefully this short 15-minute clip is helpful, just as the scene setter about like what is health promotion. Next up, I believe we are going to think about what is behavioral science, and how can you use it for your sessions. So any questions, anything you've heard, please do reach out. Otherwise, looking forward to seeing you all very, very soon. Take care. Have a lovely rest of your day, afternoon, evening. Thank you.